So we'll proceed on. And Mary, who is going to talk next, was one of our first data managers in the melanoma program here. And what she'll talk about is something that we talk with every single patient at the initial visit about. And this is becoming a part of the biospecimen repository and the protocol we call 9699 because it was the 99th protocol I wrote in 1996. So you know how we got our numbers. But it's also one that occupies our lab, and we have our new lab manager, Tony Lynn Baranowski, in the back. And it's a pivotal part, and you may ask why, but to cut to the chase, those samples that are banked there allow our fellows, our students, our academic faculty to pull samples to answer questions before we ever take them into clinical trials, sometimes to hasten the speed of our development of the new protocols. So, Mary, thank you for talking.
Thank you. Thank you for having me. So I have given this talk in the past, so hopefully this, with the stage set by Dr. Najjar with the overall summary of what clinical trials are, followed by Melissa and Darcy talking about our current TIL trials, kind of ties it all together, and you can kind of see how we do this in practice from the theory. So I will be talking about the tissue banking. Samples are only part of the issue, but what about the data? So to set the stage, what is tissue? So we're all on the same page. A tissue is a group or layer of cells that work together to perform a specific function. When you think of tissues, you probably think of tumor, which is absolutely correct, but tissues also include things such as blood, urine, stool, and other organ tissue. And in our research side of things, we refer to these tissues typically as biospecimens or correlative samples when we're conducting our research. So why is this important? So clinically, we use tissue to make a cancer diagnosis. So we need to know what type of cancer you have to treat it appropriately, what type of melanoma to treat. So on the research side, again, we use this tissue to find ways to prevent, diagnose, and treat cancer, ultimately through clinical trials. And we need a lot of samples. So if a researcher is interested in a particular type of cancer, or for example, melanoma, if you are interested in mucosal, you need to make sure we have lots of samples from different patients to do this research. So it takes often a long time to collect a lot of samples and a long time before we have results from any research that we're doing. And then we store tissue in what we call a tissue bank. So a tissue bank is just a facility that organizes these samples, stores them, distributes them to different researchers, and these tissues are often used for basic science and then later translational research. So taking research from a lab, translating it to a clinical trial for a patient, and then to get treated. And by studying these tissues in the lab, we can discover biomarkers and different molecular signals that we can then use to learn how cancer works and how we can get better treatments. And often basic science, so that preclinical testing that Dr. Najjar was talking about really begins with tissue from these tissue banks. So here at Hillman, we have two really important tissue banks, as Dr. Kirkwood alluded to, 9699. This is open here at our different cancer center locations and has been open since 1997. We have over 7,500 patients who have consented to this tissue bank and have given us samples as part of this study. And then we also have 16055. So this is open here at Hillman and also across locations in the United States and Australia. So again, we need lots of samples. So if we open these tissue banks across different locations, we can increase the speed of actually collecting the samples and the number of samples. And 16055 is graciously supported through AIM at Melanoma. So thank you to them for that. So now we have this tissue. What do we actually do with it? So again, we use it to determine how well patients respond to treatment, how well treatments work, all of those different things about why are we using treatments, how can we get new treatments approved. So typically we develop a theory and we use the tissue to help confirm if we're correct. And research with molecular testing has really resulted in us being able to find the unique features within different patients' cancers to lead us to the personalized or precision medicine. So for example, BRAF and RAS, these are common mutations found in melanoma. So we have the tissue. What are we really looking at in the tissue? And that's something we call biomarkers. So the American Cancer Society defines biomarkers as genes, proteins, or other substances that can be tested to reveal important details about a person's cancer. So these are things like proteins, DNA, metabolites, cytokines. So all of these different things we can find in the various tissues that we've already talked about. So tumor, blood, stool, saliva, all of these things, we can see the biomarkers in. And then we analyze these in the lab using various equipment and testing. So DNA sequencing, immunoassays, different PCR and microscopy. So this is how we actually identify some of these biomarkers. And then clinically, we can use these to understand a patient's risk all the way through their diagnosis, their prognosis, and then further monitoring of their cancer. So, for example, we have diagnostic biomarkers that the pathologist looks at when they're making a diagnosis. So HMB45 is a stain that the pathologists review. For prognosis, we can determine if a certain mutation will predict the aggressiveness of someone's cancer, the likelihood of it returning. And then predictive, trying to predict what treatments might actually work for our patients. So or what their response would be. So if you have a BRAF mutation, we give you a BRAF inhibitor to try to, knowing that you're likely to have hopefully some sort of response to that. And then monitoring, we use something called ctDNA, which is also known sometimes as a liquid biopsy that you could actually monitor to see perhaps recurrence or a therapeutic response. So then when we get to the research side of things, looking at tumor biomarkers, one of the things we typically look at is what we call the tumor microenvironment. So we want to know what the tumor is doing itself, but also that environment around the tumor. The tumor and the environment can play off each other. So the tumor can affect the microenvironment, and the microenvironment can affect the tumor. So we want to look at the tumor in multiple different ways because we want to get the big picture. So we want to know, is the tumor active? Is it alive? Is it recruiting other cells? Or are there cells attacking the tumor? So there's multiple techniques. This image is what we call fluorescent microscopy. And this really bright blue cell shows an active cell. So looking at this via the microscope, we can tell this cell is active. And how we get tumor biopsy or tumor biomarkers, of course, is through tumor biopsies. So we have tumor biomarkers. We also have blood biomarkers. So by looking at the blood biomarkers that are circulating in the blood, we can also assess similar things about which immune cells have been activated. So going back to the TIL, so we want to see those T lymphocyte, the lymphocyte cells. If they're in the blood, we can assess response to treatment, predict toxicity. So we want to make sure we know what kind of toxicities a patient might have, monitor for recurrence, and then really just understand how the body metabolizes a treatment, so how well it will work, what it's actually doing. And of course, blood biomarkers are coming from blood draws. We have an example of a study here from one of our tissue bank trials that used blood biomarkers. So this is one that I believe Dr. Kirkwood worked with. So they were looking to see if biomarkers are associated with immune-related toxicity, as well as progression-free survival and overall survival in patients being treated adjuvantly with anti-PD-1 therapy. And so their conclusion by looking at these biomarkers were that there were various biomarkers that were elevated when patients had immune-related adverse events. Also, there were different biomarkers associated with overall survival and progression-free survival. So this ultimately tells us, one, we need more research, but ultimately, hopefully, we get to a place where we can make better treatment decisions based upon our individual patients from these biomarkers. And then as a sneak peek, we have a really exciting study coming up soon, 25009, continuing with the study numbers here. This is a study of Dr. Kirkwood looking at the immunological effects of a combination of anti-LAG-3 and PD-1 for first-line patients. It's a corollary study, so it is a companion study to a treatment study, and we will be looking at both blood and the tumor microenvironment, so kind of pulling it together, how we use these collectively. And then Something you might not think of is imaging biomarkers. So imaging biomarkers provide a really valuable information about the disease itself, progression, response to treatment, and it's a non-invasive way to assess tumors within the body. So 20049 is a study of Dr. Devar that is now close to accrual, but this had a sub-objective of looking at this RAG PET scan to correlate with pathologic response and other biomarkers in neoadjuvant treated patients. So this image is not from Dr. Devar's trial. However, it's here just so you can kind of see that looking at our typical PET, which is the FDG F18 on the left, and then looking at this RAG PET where you're seeing the same tumor, but it's lighting up in a different way so that they can assess these biomarkers. So again, trying to pull this all together, these biomarkers lead us to these clinical trials. So this is a SNP from Dr. Kirkwood's 18071 trial where you're looking at tumor biopsies, these blood draws, and then RECIST, which is not a biomarker in this instance, but a way to look at the disease to get that overall picture of what's happening with these patients and how we're going from looking at the science to a treatment with our patients. So this, again, leads us to clinical trials, which Dr. Najjar explained to us already, but these are written, again, by the researchers and the biostatisticians to really answer a question. And as she noted, typically we have one big question that we're trying to answer, and we use objectives and endpoints to do that. And then, as she also alluded to, many times we are looking at the safety and efficacy of these treatments. And the safety are the adverse events or the side effects, and the efficacy is the disease response. So again, trying to give you the practical application of this. We have to collect the data. So we collect the clinical characteristics of our patients, so age, gender, date of diagnosis, because we want to make sure we are comparing groups of patients, because a treatment might work great in one population and not well in another. So we're also collecting cancer information, mutations, prior treatments, medical history, medical problems, medications, all trying to see if any of these things are influencing a patient getting the treatment on the trial. So for data, this is just an example of how we kind of correlate the patient characteristics with the different arms in a particular study to tease out, the different groups. So going back to the tissue banks are really well organized, because if an investigator wants a sample, we need to know where it is, what type of sample. So again, if you are looking at a specific patient population, we know we have X amount of samples for X diagnosis. So we're looking at sample identification. So having a really well-defined identification process, knowing what kind of specimen it is. So is it tumor? Is it tissue? Or tumor? Is it blood? Is it stool? That kind of thing. And the collection date is also very important. This is an example from a database, what kind of data we collect. So the anatomical location, the tissue type, the diagnosis, the clinical aspects of that. So the breast load depth, ulceration, if those things are known from the pathology, those are the kind of things that we're collecting, for an example, for a tumor. On the clinical side, looking at clinical trials for safety, we look at adverse events, which again are these side effects. So our investigators are trained to really look at each adverse event and determine if it's related to treatment or not. So we start always with the event term. So what is the adverse event or side effect the patient's reporting? And we collect every side effect. So if you trip and fall down the stairs, we report that as not a side effect, but we report that as an adverse event on the trial. We use a standard method to grade these. It's a tool so that we are using a consistent method across all patients and all trials, all diseases. And then again, our investigators are the ones making this assessment. Is it related to treatment, or is it related to another contributing cause? So weight loss, is it because the patient was nauseous and they aren't eating, or is it because they're on a diet? So those are the things that investigators are teasing out. From efficacy, we're looking at disease response. So is the disease getting better, staying the same, or getting worse? So when Melissa was presenting, she showed the overall response was 32% for the TILs, and she had a partial response and a complete response. So this is what this is showing. So in this example, we're taking the radiology scans where within the red, we have the tumor, we're measuring it, and then we're using this RECIST that Darcy alluded to ensure that we are collectively looking at all these tumors in the same exact way, measuring them, and then we get our response. So in this example, this patient had a partial response because their tumor decreased by a certain percent. So that's kind of how we pull it all together. So what do we do with this data? We enter it into a database that is then analyzed. So we have many different types of databases we use to collect our data. Medidata Rave is one, Inform is another common one. REDCap is the screenshot you see here, and this is what we use for our internal UPMC trials. So the ones that our doctors write, this is the database we're using. So we also might send information to a sponsor for collective analysis as well. So going back to those tumor samples, the blood samples, for imaging for any radiology, so CT scans, MRIs. If it's a trial with radiation, we might send the simulation and the treatment plans, and then quality of life and or patient-reported outcomes are really important, going back to our patient question about long-term side effects. So we really care about this stuff. So these often are either paper, which we're entering into a database, or if there's something like a tablet or a smartphone app that gets routed to the sponsor as well, again, for that collective analysis. So what else can we learn? So the main objectives of these clinical trials typically are safety and efficacy, but the secondary objectives often include this tissue research, which is where, again, these biomarkers come into play. And these are used to determine changing tissue, how the treatment is changing tissue, changing the patient's, the body's immune response to the treatment, to the tumor. And our goal is to build more clinical trials and build the science for future treatments to work better. So again, pulling it together, the data is correlated from tissue, is correlated with the clinical information from the patient. With the help of the biostatisticians, we collect an analysis of this. So we're looking at those different characteristics, the tissue, and ultimately we are reviewing this in the context of the objectives to see how well the treatment worked if we met those objectives. So this leads to the new treatment approvals. When statistical analysis shows the treatments are safe and effective, we submit for the FDA approval. The FDA has a very, very thorough process for reviewing data. They'll come on site and confirm we followed the protocol, the data that was entered was accurate. And then ultimately, hopefully we have new treatments approved. And as previously mentioned, the work we do here absolutely translates to these new treatments. You've seen from Dr. Najjar, all the different trials we've worked on. So here's an example of all the different drugs that have been approved, and we've worked on trials for most of these agents. So as a summary, just why should you give tissues? Because it contributes to the advances of science. This is really where we base our research. We start with these tissue, and this leads to our clinical trials and treatments. So you can help us find a cure. You can help drive future research. You can take an active role in your healthcare and learn more about melanoma and the treatments. And this, as Dr. Najjar pointed out, is always voluntary, so you can always withdraw your participation. So with that, thank you to everyone who's participated in our trials, given tissue for our tissue banks. And without you, none of this is possible. So thank you.
Thank you, Mary. That was a wonderful talk. And in fact, those tissues are the impetus to many of the advances that we have. And Mary is now the director of the clinical trials office here. And so she makes sure we stay on the beam and that they're all done in absolutely perfect fashion.